session in which we are going to focus predominantly in terms of technological advances with regards to pediatric endocrinology. And we know pediatric endocrinology is one branch which has witnessed a lot of changes. And often when we talk about technology, we traditionally have been talking about how new devices have come up, or whether you've got a new way of giving glucose monitoring, or you're doing some new insulin. But what we're talking about technology today is to how these protocols are properly implemented at the last point. And this is what the aim is, to develop point of care tools which can help out in terms of improving technology. So our aim has been to develop tools which can be implemented in different regions, across resource settings, across the different exposure in that regard. And we'll be focusing about how these point of care tools can help guide 5 key disorders in the form of growth, puberty, thyroid, glucose, and electrolyte disorders, and how we can individually look at in terms of evaluation, assessment, and management of these disorders. Epidendo basically is a way in which we want to go out in terms of developing tools which will help in terms of evaluation of these key disorders using a very novel approach of mobile application, which has been there now for some time, but we have been keep on editing them in terms of improvement. So our work with regards to pediatric endocrinology actually started maybe around 13-14 years ago, when we started with workshops on different disorders. This was much early. Then we gradually developed those workshops into 6 modules, which were in the form of a practical pediatric endocrine course, which we conducted across the country. Then we realized it's going to be difficult to keep on conducting programs in that extent. So we went on to social media in terms of YouTube, in which large number of videos were available. We started an on-site fellowship around 6 years ago, and till date we have got 11 fellows who have joined who have done or are doing the clinical fellowship in that regards. Then we realized that we also need to spread out the message, and that led to the development of Medi classes around 5 years ago, which is a portal dedicated towards improvement in pediatric endocrinology, which then further led to the publication of multiple books, and then the mobile application. And we are going forward in terms of these regards, and we'll talk about the subsequent developments which are happening in that regards. One of our important interventions is the e-learning tool, which is in the form of a YouTube channel, which has got extensive resources. Pretty much everything about pediatric endocrinology is there, and it's quite widely viewed across the globe as well. We have got our website, learning.growsociety.in, which provides validated courses with regards to various aspects of pediatric endocrinology, and they range from small courses like growth, puberty, to more specific and larger courses in the form of the fellowship programs, as well as the pediatric endocrinology for postgraduates and other programs in the form of, which are available on an online or an online on-site hybrid model. We have got 3 key books which focus from practical approach to basic to advanced pediatric endocrinology, which provide a comprehensive understanding of these tools. But what we realize essentially is that with all the knowledge and resource, ultimately, when you are seeing the patient for the first time, you may get puzzled in terms of how to implement all the knowledge, and therein the confidence becomes a bit difficult. And whatever you remember will not always be a sort of a standard of care, and often that results in errors. So there is a need in which we really combine between the knowledge which is there in terms of available, in terms of resources, in terms of guidelines, in terms of algorithms, with what we really practice in that regard. So how do we do that? There are multiple factors required. You need to decide about which tests to order. You need to look at the interpretation of each and every clinical sign, as well as the investigations. You have to then decide about what treatment is there, and that's why you need to have a very comprehensive approach on that. So we tried to develop a solution which can help out in all of these things in terms of analyzing the symptoms, interpreting the key parameters, advising investigations, then comprehensively looking out on investigations and deciding about that treatment. And we realized that the most powerful device there would be a mobile application, because if you think of it, mobile app is available to everybody, and all of us keep carrying that mobile everywhere. If you talk about, let's say, a web portal based approach, it requires at least an office setting. So this can be used across settings, very easy to do, and you just develop and can be used across the globe as well, providing same standard of care at different regions in that perspective. So this led to the development of our mobile application, which was developed a few years ago, which is in fact the most downloaded endocrinology app all across the globe, with number of installs and a lot of publication that we have done in that regards. The way we structured this is to develop pathways which provide us guideline-based approach in an algorithmic manner. You have to question and answer, and you will get the final diagnosis in that regards. There are approach pathways and management pathways. So they will guide stepwise management and approach. Suppose you want to know about hyperkalemia, it will ask about specific conditions, and then we'll go in terms of diagnosis. More recently, we move more towards interpreters, which are instantaneous, because now the general tendency, you don't want to go and wait for a long time. So you just put in some data, like in the form of a thyroid interpreter, you interpret the thyroid results and you get the results automatically. Similarly, the bone age interpreter, which has been published and validated, which provides a wide, and we'll discuss about this tool as well as more disease-oriented interpreters, in which based upon your symptoms, we will then decide about what workup is required and how do you reach a particular diagnosis. So we've got multiple interpreters like puberty interpreter, obesity interpreter, DSD interpreter, which really guides, and we are working on a combined electrolyte, calcium, and glucose interpreter, which is going to help out in that perspective. Now, once you order a test, you need to really understand the intricacies of when to do, how to interpret, and age-related. So, of course, we don't have all the information, and that's why we have put it every detail in the diagnostic section and information about every drug in the therapeutic section. So within the app, you can actually, once the patient comes to you, decide about what investigations you want to do. You can then decide about how to send and all the information is there. Once the results get in, you can interpret those results, then you can prescribe and you can know about the particular drugs as well. So we sincerely hope that this endocrinology application is the bridge between the evidence base and the practice. So this is expected to result in evidence-based practice, and we already have publications which have shown its improvement in care in terms of decay, growth, and bone age assessment. And we are working in terms of validation for many more disorders like diabetes, DSD, puberty, obesity, thyroid, and this is a most common presentation which will be there in a pediatric practice. You have a 12-year-old girl whose height is 132 centimeters, weight is 20 kgs. Now the quick question is whether this child requires evaluation or not. The most common presentation to a pediatrician. So as I said, 2.5% of all children will be short, but most of them will be physiological. And this is true for most endocrine conditions, whether you talk about growth, whether you talk about obesity, puberty, most of them represent a physiological variation. And maybe 10% will have a significant pathology. So what you want to do is to not unnecessarily work up these 80% physiological cases, while you don't want to miss these 10% who can have a life-changing disease like celiac disease or a life-threatening disease like craniopharyngioma. So this is the work there. So now if I talk about growth failure, this is from our review paper in IJP, which talks about the various forms of growth failure. Essentially, when you talk about growth failure, as I said, 80% is physiological, which is characterized by a child who is, even if he's short for the population, is not short for the bone age and not short for the family. And I think this is the three things to remember. If you are saying a child has a pathological failure, he would be short for the population, short for the bone age, and short for the family. So if he falls in any other, it becomes physiological. Then 20%, 10 to 20% may have pathological forms. Then you may have a problem either at the level of the growth plate or at the level of environment. So when I talk about primary problem in the form of growth plate, cellular scenarios, you may have a SGA who may have a symmetrical SGA who is not catching up. You may have a syndromic cause which is there in the form of various syndromes like Turner syndrome, Russell-Silver syndrome, and Shock's defect. Then you can have skeletal dysplasia and rickets, so intrinsic problems. Then secondary problem, which are the most common causes in pathological causes, will either be a nutritional or an endocrine cause. So this is the key thing to remember. Nutritional will basically mean all the malnutrition, malabsorption, infections, while endocrine will be the hypothyroidism, growth hormone deficiency in that regards. So when we have a child with growth failure, the first question, of course, is it really short stature? Then if it is short stature, is it pathological or physiological? It's primary or secondary. So we'll now start off with our publications, which clearly shows that how do you define growth failure? So Vibha, can you tell me how do you define growth failure? You can start. Now, in terms of general definition of growth failure.
So in the general definition of growth failure, like if the child is if we talk about the community, if the child is short for his peers, for his classmates, then definitely this will be an objective, subjective parameter.
We have been comparing it just with the normal population. But then it means that everybody who is below 2.5 centile will be short.
Yes, sir.
If the whole population becomes tall, everybody is above 6 feet, those 2.5% will always remain short. Sure. So what we try to look at it is what makes more sense in terms of the criteria. So whenever you talk about diabetes criteria, how is the diabetes criteria of sugar of fasting 126, let's say?
Sir, if the sugar of is more than 126 and if this
so why do you use 126 and not 116 or 136?
Sir, because most of the patient with that sugar level of more than 126, their sugar is really high. They'll have symptoms of.
You have to look at complications. So what are you worried about? Long-term complications. So studies will say, okay, a level more than 126, your complication increase. A level above 100, slight increase. So then you will say this is pre-diabetes and this is diabetes. So same what we did was to look at what is the prevalence of pathological short stature with regards to severity of height. So if you look at somebody whose height standard deviation score is more than -2, the risk will be very, very low. But when you go to around -2 to -3, it becomes 40%, and less than -3, it becomes 80%. So 80% children who come to you with a height SGS below -3 have a pathological cause, which means that they need definitely evaluation. So if you now look at it, we have a traffic light approach of more than -2 SGS, you can wait, -2 to -3, you can have wait and watch, and less than -3, you need to work up from that regards. So how do you define this? You can carry from here in terms of the growth chart and everything.
So if we look into the growth chart, if the child, if we plot the height of a child and it is falling very below the 4th percentile, then this child really needs workup. We cannot miss this child. And if a child is not growing at all, at the height growth velocity of less than 25 centile, is height standard, it's between the 1 and 3rd percentile, then this child also require workup. And if we look into another scenario where the child is not growing at all, it means the child, the height of the child is passing more than 2 centiles, significant centiles, that in these 3 scenarios, the worker has to be done, and this is the definite case of short stature when we have these kind of child and we plot these child.
Of these 3, who will you be the most concerned about?
So the child not growing at all.
So somebody who is not growing at all would mean that they have a acquired cause. They may have a brain tumor for all you know. Yes, so you will be more worried about that. So these are the conditions you will require evaluation.
So if we go by the algorithm, definitely sir has told us the first question is whether to evaluate the child really requires evaluation in terms of investigation or workup. So yes, first step is to identify whether the child is short or not, whether it is pathological or physiological, because definitely in physiological, we need not to require do lots of workup. And so coming to the physiology versus pathology, because differentiating these two entities is really important and difficult also. So for this, we use the basic one, that is the growth chart. It is very helpful in the differentiation, along with the assessment of pubertal status and with the bone age assessment. As most of the pediatricians are not very well trained in the growth chart interpretation, assessment of the puberty, and also the bone age assessment. So it becomes really difficult for them to differentiate between the physiological versus the pathological. So these basic following basic identification in these growth chart and pubertal status and bone age, we can really do wonders. So if we look into the growth chart, the first step is to see the absolute status of the child. That is where the child lies in the growth chart. It could be measured in the percentile as well as in the height SGS. Now, second step is to measure what is the children's height in comparison to his or her parents. And for this, we require the target height. And how do we calculate the target height? It is we add the father's height with the mother's height and divide it by 2. And in case of boys, we add 6.5 and subtract 6.5 in case of girls. But the target height SGS is also very important because we have to see what is the status of the parents with the reference population. And there is one important parameter that is known as the corrected height SDS, because it will definitely differentiate whether the child has the familial cause of short stature or the non-familial one. So for the assessment of corrected height SDS, we have to subtract the target height SDS from the height SDS. And if it is greater than minus 1.5, then this is the familial pattern of short stature, and we need not to do any investigation. We can follow it up. And if the corrected height SDS is less than minus 1.5, then definitely we need to follow this child for a long, and some investigations will be required. Now, coming to the differentiation between whether the growth pattern is nutritional or endocrine. Here, the importance of height and weight age comes. And as we all know, if the height is very much affected than the weightage, then this will go in the favor of endocrine pattern. But if weight is more affected than height, then it will be nutritional pattern. But we require an objective parameter so that we can easily differentiate between the nutritional and the endocrine pattern. And from our own study, we have evaluated that BMI SDS is very important parameters. On the basis of it, we can really differentiate it.
So there are two schools of thought. One, people who talk about the percentile values and the growth chart. So they will talk about what is the percentile, what is the target height from the chart, and height and weightage. And the other one, which will be talking more in terms of what is the height standard deviation score, corrected height standard deviation score, and BMI SDS. So what we need to understand that this is the same thing which is depicted in a different fashion. Which one of this will give you a more objective parameter, SDS or a percentile?
Sir, SDS, I'll say.
So I would say that we need to, as a pediatrician, move from this percentile-based approach to a more SDS-based approach. Why? Because if you say less than first centile, it could be 0.001 centile or just 0.99 centile. But if you measure SDS, you will know that this is minus 2, 2.2, 2.4. You can be more continuous variable will be there in that regards. Number two, if you are following up, somebody is less than third centile and he remains less than third centile, what does it mean? So better to go ahead in terms of height SDS. So remember these three parameters when we talk about our algorithms: height SDS, corrected height SDS, height standard deviation score for bone age. This is another parameter which will come up. These three will really tell you whether the child is really short. If he is short, is he short for the family? If he is not short for the family, then whether he is short for the bone age or not, and this will give you a clue. And BMI SDS is much better than the height age weightage perspective in that regards.
So keeping in mind all these parameters, the height SDS, the target height SDS, and the BMI SDS, as most of the growth calculators do not provide the corrected height SDS and the height SDS for bone age. So, and we have made it possible in our growth interpreter, where you have to put all the data regarding the age, height, weight, and it will give the likely interpretation in the form of BMI SDS, weight SDS, and height SDS. So coming to the pubertal progression in girls, and it is very important to know when there is an onset of puberty. And for it, the stage B2 plays a very important role, because from here there is an onset of puberty. And from this stage of B2, there is a growth spurt of 20 centimeters from here to the final adult height. But we must keep in mind that it should be differentiated from the lipomestia, and we could easily differentiate by approximating the index and the thumb finger. And if there is a resistance between the thumb and the index finger, then definitely there is a breast node present, and if not, then it is a lipomestia. Now, the breast stage 4, the height from the breast stage 4, generally the child gets about 10 centimeter from this stage, and from the Minaki, the child is able to attain at least 5 to 8 centimeter. And in case of boys, the main thing that we keep in mind is the testicular volume for the pubertal progression. At the testicular volume of 4 ml, there is an onset of puberty, and at the volume of 10 ml, there is a growth spurt.
So I think the other thing to remember, therefore, most people, pediatricians, do not want to really look at puberty, or it becomes very difficult to them to really assess puberty. So what we suggest is that just look at breast. You may have palpation only if you have a doubt between B2, whether it's there or not. Otherwise, looking at breast, look at B2 and B4. These are the two parameters which become very important. And for boys, testicular volume of 4 and 10 ml. So I've been talking about short for the family. short for the bone age, there is also a concept of short for puberty or not. So if you have a height of 130 centimeters and breast stage 2, you are expected to grow another 20 centimeters, you will be like 150. But you are 130 at a breast stage 4, you only will grow 10 centimeters, you will be 140 centimeters. You have got 130 centimeters at menarche, you will go 135 centimeters. You have got 130 centimeters with vaginal discharge, maybe 7-8 centimeters. So you need to keep your minds open. Similarly, in boys, if you have TV of 4 ml, you expect 20 centimeters to 25 centimeters growth. TV of 10 ml means the spike is going to happen now, maybe 15 centimeters or something. TV of 15, you start getting worried. So this pubertal assessment should always be commensurate with height. We have developed the interpreter which really helps you pictorially identify that. And in certain scenarios where sometimes it's culturally difficult to really get the pubertal assessment in a busy practice, you may actually ask the attendants or the child themselves to rate, especially for the female patients, we have found it to be reasonably good. In boys, of course, testicular volume has to be assessed very importantly. So this could be a surrogate marker in that regard.
So after the pubertal assessment, the next very important step is the assessment of the bone age. As we all know that maturation starts from the proximal to the distal and the fusion of the bones start from the distal to the proximal. And in the very early age, like in the infancy, the number of carpal bones could be used to assess the bone age, but later on the short bones and the long bones are important to assess the bone age. And girls are generally advanced by 1 to 2 years because of the effect of the estrogen. And what we look into these short bones, actually we measure the size of the epiphysis with the metaphysis. And if the epiphysis is shorter than metaphysis, if it is equal, or if its scapping starts, then we can decide at what age the child is. And this is a very important picture which shows that the carpal bone and the number could be used in infancy and the toddler. And what I am talking about, the epiphysis site. When the epiphysis is smaller than the metaphysis, then it will be around 2 to 7. And if it is equal, the bone increases. And it is important to look when does the capping start, because from there the child would be around 10 to 12 years. And later in the puberty, we have to look for the fusion of the long bones as well.
So bone age has been one tool which has often been neglected in terms of practice because people have not been trained that much. And if at all, people just count how many carpal bones are there. What I'm trying to say is that take your focus off from the carpal bone to these distal phalanges. These are the most important ones. And if you have to look at one, it will be the middle phalanx of the middle finger. And then you just compare what is the epiphysis and metaphysis. And if you look at the ages, it's 2 to 13. This is the time when you want to do bone age. You don't want to do bone age less than 2 years. You don't want to do bone age beyond 16 years. That becomes very easy. So the most important thing, and studies have shown single side, you want to look at it, middle phalanx of the middle finger. You will get a good information. But of course, you want a more objective assessment. There will be other tools which are available. So which are the other tools which are available, Vibha?
So other than this extra, we have a GP atlas where the X-ray of the patient is compared with the specific age atlas that is provided in the GP atlas. It has very intra-observer and inter-observer variations. The next we have Tanner-Whitehouse 3, where the 13 sites have been selected. And according to the maturation, individual score is provided to every site. Then the score is converted to bone age, and calculatively the bone age of whole hand is assessed. But this is very time consuming, around 10 to 15 minutes generally is required for the assessment. And the next we have is the bone expert. It is fast, it gives an quite accurate image, but the most disadvantage is it is very costly. So we have developed and validated a novel application for the bone age assessments. As Sir has told us that the major 5 sites have been selected in our study, and they have shown that if we do the bone age by selecting these 5 sites, it will give a much accurate results compared to the Tanner-Whitehouse bone age expert as well. So what we have done and how do we calculate the bone age assessment in our application? First, we have to select the middle phalanx of the middle finger. Then we compare this image with the images provided in the app. Like we select middle phalanx of the middle finger. Then we select the proximal phalanx of the middle finger. We compare the ulnar the radius and the proximal phalanx of the thumb. Then after selecting all the sites, the app will immediately gives us the bone age, which is very fast and very accurate. So after assessing the bone age, the pubertal status, and the growth chart, the next step is to what test should be done and in what order. So growth chart, puberty, and bone age is required in all the cases. They should not and they must not be missed in any cases. So, and for the differentiation of pathological short stature, for primary one, we should and we must look into the syndromic facies, the proportion of the body proportions, and in the SGA, we must make a habit to ask the birth weight of each and every child, those who come to our clinic. For this Turner syndrome, the SOC deficiency, karyotype is must in all the girls. And for the skeletal dysplasia, detailed skeletal survey is required. And in the nutritional causes, we need to do liver function tests, creatinine, TTG, so rule out any systemic diseases. Blood gas and calprotectin for the IBD. Coming to the endocrine causes, we need to do the free T4 TSH, the thyroid profile, the GH stimulation test, but they are done after ruling out each and every causes. So if I conclude, CBC, ALT, creatinine, TTG, FT4 and TSH has to be done all the patients who presented to our OPD with short stature, and karyotype is required I will say karyotype should be done all the girls with short stature. Blood gas should be done below the 3 years of age and calprotectin above the 10 years of age. And in case when all these investigations come normal, then only we should proceed for very specific tests like growth hormone stimulation test and other sort of test.
So if we go by the approach now, if we use our more objective criteria, so we say look at height SDS, first the child is short or not. If height SDS is above -2, then don't worry at all. This child is not really short, no workup required. If height SDS is -2 to -3, then look at the family, whether the child is short for the family. Look at the corrected height SDS. If the corrected height SDS is within the 1.5 range, so 1.5 SDS plus minus of the family, that's normal, this is familiar. If, however, it's less than -1.5, then you look at whether the child is short for the bone age or not, and you look at using a height standard deviation for bone age. If it's less than -2, then you worry. If it's more than -2, then it's nothing. So 80 to 90% of cases will come out here. They will have a height SDS more than -2, a corrected height SDS more than -1.5, or a height SDS for BA more than -2. And in all these parameters, you do not require any evaluation. You just follow up, look at puberty, and go from there in that regards. However, if child is short for the family, short for the population, short for the bone age, do the screening, which already Vibha has talked about. We do recommend TTG in everybody, even if you have a nutritional or endocrine pattern. Blood gas only before 3 years of age. If these tests are normal, you can follow them up. However, if you have a child who is very short, who is below -3, then don't wait much. You can follow up and work up. Look for syndromic features. And then if they are not there, go for two things, IGA and karyotype. So we do not recommend IGA right at diagnosis because the yield of IGA is not too much. And karyotype also not in somebody who has got all the features of Turner's, but anybody whose workup is normal, you should do a karyotype at that point of time. Once that's normal, you go for growth hormone stimulation, IGF-1 and other workup, but that's the last investigation to be done in that perspective. So the key parameters are, again, as we started, look at the growth chart, bone age, parental height, and you will get the idea along with that in most of these cases. So based upon this algorithm, we have developed our tool, which was found to have a high level of concordance with regards to clinical diagnosis to the tune of around 99%. All you have to do is to put the data, what is the current height, what is the current weight, parental height, and you will get an output along with likely diagnosis in that perspective. And from here, we have tried to build it up further with the development of BIG, which is bone age assisted interpretation of growth. So Vibha, maybe quickly tell us about this.
Yes, sir. So this is slide. Okay. So BIG, it is definitely it is not available in mobile. It is a web portal and it is very simple to use. What you have to do, you have to input all the key anthropometric parameters Then select the pubertal status according to the images given in the portal. Then select the specific sites for the bone age assessment, and you can do either by the manual entry or by the selection specific sites. Then based on the Big provide an instantaneous pictorial growth chart, which includes the bone age, the mid-parental height, and along with the detailed interpretation of various growth parameters, including the target height SDS, corrected height SDS, and the height SDS for bone age, which is very important for classification of different growth disorders, along with the bone age report. And it also provides the specific interpretation with guidance, and it on the follow-up, it also provides the tracking form.
So we have tried to club all our algorithms into one, and this will just give you an instantaneous interpretation of growth, puberty, obesity, all the parameters. So let's start with cases. Your 12-year-old girl, height is 132, weight is 20, father is 163, mother is 150. Do you think this child is short, Vibha?
So if we see the child's present status and on the growth chart, definitely the child is below the 3rd percentile. So definitely the child is short for his population, for other children's. But
you would like to have a look at the parental. So
definitely,
this is the parental height. And we have used these graphs, which will give you the upper and the lower limit. So typically, we talk about 1.5 standard deviation. So plus 1.5 minus 1.5. So now do you think this child is short?
So on the comparison with the parent height, this child is coming within the this height range of the parents. So definitely the child is not short for his parents, but we have to look for the height age and the weight age as well.
So what is really the height age and weight age? It's basically the age at which the current height and weight becomes the 50th percentile. So you draw basically by joining the 50th percentile and joining a perpendicular. So what's the height age, weight age here?
So height age and both is 9 AM, both are lower than the chronological 8. And here the role of our growth interpreter comes when we give all the inputs to the growth interpreter, then it will give the instantaneous interpretation about the BMI SDS, and we look.
So if you look at it, we have given the interpreter and it gives us this report. So what if we go with one of these parameters, it's basically saying that height is below -2 standard deviation score, but the target height SDS is -1.37, which means that she is not short for the family. So this becomes the familiar. You don't need to do any workup from here. But the important thing to remember that often we forget about weight.
Yes.
So you see the BMI is -3. That's why this underweight has come up. So if you use this simple tool, you will not miss these pathologies very clearly. So I think that's important.
Yes, sir.
So this is familiar short stature. Second case is 12-year-old, height is 120, weight is 15. Now what we are seeing here is that workup showed TSH, TTG were normal and growth hormone level basal was low. IGF-1 level was also on the lower side, diagnosed as growth hormone deficiency. So do you agree with this diagnosis?
Definitely not, sir. First of all, we cannot rely on the single basal hormones level. We need to plot the patient's height on the growth chart.
If you look at the chart here, what you are seeing basically is that what seems to be more affected? It seems to be the weight which is much more affected. And if we go to the individual result, what you are seeing here is that height SDS is -3.85. So height is much affected, but the weight SDS is -4.88. So what does it mean?
It means the BMI SDS is less than -2, which is going in the favor of nutritional.
So BMI is -3.7, which means nutritional pattern growth failure. So does this fit now into growth hormone deficiency?
No, sir.
So it basically means that we are not having the right diagnosis. So we got the IGA done, which was undetectable. So always interpret the growth chart as per the correct reading and then order the investigation. Otherwise, you would be confused. Next case is a 10-year-old boy who is short, weight is 18 kg, parents are short also, bone age is delayed. Now this child, the workup showed a TTG of 32, and based upon that, they had diagnosed that this is mostly celiac disease, that why is gluten-free diet, but there was no effect. So do you agree with the diagnosis of celiac disease in this case?
So first of all, we have to see whether the which height age is affected or weight is more affected, and the growth interpreter definitely can help us in this.
So if you look at the growth interpreter,
the height, we can see that height is more affected than the weight, right?
And if you look at these objective parameters, what do you find? You can interpret it for me.
So we can see the height SDS is very low. It is minus 5.68 standard deviation, and
so
weight is
short for the
population.
Then
and the weight SDS is minus 2.7, which is also in the lower side, but what we are seeing that BMI SDS is 0.6, which is greater than 1, minus 1. That is, it is not going in the nutritional.
Short and plump. So if you have a short and lean, that becomes nutritional. Short and plump becomes
endocrine pattern. And correct.
He's not short for the family as well.
So he is short for the family.
He's short for the family. So minus 1.41. And corrected height SDS?
Minus 4.27. Definitely he is short.
Very short. And height SDS for bone age. So he's short for the bone age. So he's pretty much everything. He's short for the population. He's short for the bone age. He's short for the family. And he is heavier than his height. You can say that. So this is a short and plump child. So this classically suggests that we are dealing with a case of endocrine pattern of growth failure. So this diagnosis of celiac is wrong. So what do you think was wrong in this case?
So PTG is 32, sir.
So we should have done something?
We should have done the IgA level as well.
So we should have done a biopsy to confirm that this is really celiac. Obesity is also a very common condition. Now 5 to 6% may be actually obese. Most of them are physiological. 98% of children with obesity are physiological. Only 2% will have a disease. So it's even more important than short stature to be careful about that. And you need evaluation. So when we talk about obesity, what are the parameters which will tell you that this is physiological versus pathological obesity?
So we have to look for the height, the development, the pubertal status. That will help in differentiating the pathological.
So normal growth, normal puberty, normal development would mean this is physiological. If you have compromise of these, you start thinking of a pathological cause. So the most important thing to look at in a short child is the weight. Short and plump, endocrine, short and lean nutrition. The most important thing to look at in an obese child is the height. Obese and tall is constitutional. Obese and short, again, you go to endocrine cause. So pathological causes, if you have very early onset with hyperphagia, visual abnormality, syndromic features, start thinking of genetic causes. Of course, if there is drug history of steroids, valproate, you will get hyperphagia. And endocrine causes are extremely rare causes of growth failure. In our own study, it's only 10% of all causes will be having a pathological cause. So even in a referral center, only 10%, but in a pediatrician, it will only be 2%. So growth, pubertal delay will give you a clue. So what will be your approach for obesity?
So first we have to see whether what is the weight of the child. If it is more than 97 percentile, definitely the child is obese. And if there is the child does not fit into the obesity criteria, then we need not to do any workup. And if it fits, then we have to see what is the age of onset of the obesity. And if it is less than 5, definitely the BMI plays an important role. And when the BMI SDS is more than 3, then definitely for the child less than 5 years, we have to go for the genetic workup in this case. And in case of less than 5-year child and the BMI is less than 3, we need to look for the syndromic features in the patient. And if there is a abnormality in the development, there is a vision problem, or there is any dysmorphism in the facies, then we should go for the genetic studies. And when the height, when there is no syndromic features in the child, and then we have to look for the height SDS, whether the child is tall or short. And if the height SDS is less than 0.5, then the endocrine workup is required. And if it is less than minus 0.5, then definitely we need to screen for the complications like blood sugar, lipid profile, and BIA.
So most important parameter, of course, is to look at what is the age, what is the severity, and other growth, which will give you the criteria. So based upon this, we have developed an obesity interpreter, which provides comprehensive guidance based upon simple parameters. And again, we have found that a large number of it has got huge concordance. And as you can see, 92% actually, this is the precise figure, 92% actually had a physiological cause. So even from an endocrine center, 92% are physiological. This is a big message. Now we have a 12-year-old boy who is height of 160, weight is 70 kg. Parents are not very tall. The bone age is all right. Now this child comes to you with a TSH of 7.91 and has been started on thyroxine. Do you agree with this or not?
So first of all, the child is obese. As we can say, he's having 70 kg of weight in 12 years, and the TSH is 7.9. So definitely we cannot rely on this TSH. We need a FT4 level as well. And if we use the obesity interpreter in this child, we'll see that BMI SGS is more than 27 kg per meter square.
Yes. So he is obese, but is he short and obese or tall and obese?
So as we can see in the interpreter, the height SGS is 1.7. So child is definitely not short. Weight is 2.51. Definitely he has more weight. Obese child.
Tall. So it is unlikely to be thyroid, and this is the effect of obesity,
not the cause
of obesity. So borderline cases, you may do a TPO. Mostly it will be negative. You don't need to worry about. 12-year-old girl, similar age, but she is short and she looks obese. Her basic tests were normal and she had a rapid weight gain. Now, if you look at this growth chart, what do you think, Vibha?
So here we can see the height is much more effective. The height age is lesser than the weight age. So here we can say the child is short and plump. So this is more going to the favor of endocrine pattern.
If you look at the output from our obesity interpreter, will say a pathological obesity. So again, key things to look at. So what obesity interpreter does is it makes life very simple as to you don't want to miss on cases. And this actually turned out to be a Cushing syndrome.